Thank you very much for the invitation. I'm Billy from Emory University. I'm going to talk about understanding your pathology report. You're very familiar with your family physician, ER doctor, surgeon, but who are pathologists? Pathologists are the physicians doing all the testing in the laboratory, bacteria or viral culture, and tissue diagnosis. Pathology generally have three categories: anatomic pathology, clinical pathology, and forensic pathology. You're probably very familiar with forensic pathology from the TV shows. Anatomic pathologists make diagnosis on tissue samples that include biopsy, fine needle aspiration, and surgical specimens. Clinical pathologists do all the testings, including chemistry, blood banking, microbiology, molecular pathology, hematology, and immunology, and other specialties. This is a famous book from a giant of anatomic pathologist, Huang Rozai, Guiding the Surgeon's Hand. In the hospital, pathologists, especially anatomic pathologists, are the best friends of surgeons. Now I'm going to show you how we are going to examine your breast specimen after surgery. This just shows the anatomic structure of the breast. You have the areolar complex, you have the nipple, you have the lactiferous ducts, and you have the lobules in the breast. And also you have the lymph nodes. The lymph nodes generally classified by different levels based on anatomic structures. This is a lateral view of the breast. They include the areolar complex, nipple, lactiferous ducts, and lobules. By surgery types, generally there are three surgery types: lumpectomy, partial mastectomy, segmental mastectomy, excisional biopsies. They're more or less the same surgical type. The surgeon will take part of the breast tissue. Simple mastectomy, skin-sparing mastectomy, and nipple-sparing mastectomy, they're more or less the same. The surgeon will take the entire breast. Skin-sparing mastectomy, the surgeon will take minimal skin lesions. In nipple-sparing mastectomy, the surgeon will leave the nipple in the patient. Modified radical mastectomy include the entire breast tissue and also lymph nodes. This just show you a lumpectomy. The surgeon will make a small incision of the skin and take part of the breast from the patient. Simple mastectomy, the surgeon will take the entire breast tissue. Generally will take a central lymph node, but generally the entire tissue doesn't include the lymph nodes. Modified radical mastectomy, the surgeon will take the entire breast tissue and also the axillary content that include the axillary lymph nodes. So who will benefit from lumpectomy? Usually lumpectomy is performed on patients with early breast cancer, limited ductal carcinoma in situ. That's carcinoma still is in the in situ process. And those patients are generally followed by radiation therapy. This is one example of the lumpectomy specimen we received from the OR. This is part of the breast tissue. This breast tissue is oriented by short stitch. Generally, is the superior aspect of the specimen, and long stitch generally designate the lateral aspect of the specimen. So after we receive this lumpectomy specimen, we ink 6 surfaces with different colors. Just imagine this breast tissue is a box. There are 6 surfaces. So we're going to just ink all surfaces with different colors so that we can evaluate the margin status on the microscope. And then we'll slice the specimen into thin slices, generally 0.5 to 1 centimeter thick slices, and lay all the slices on the examination board to thoroughly examine the entire specimen. This cartoon shows you how we examine the specimens, specifically lumpectomy specimens. We ink all these different colors. Then we slice this specimen into thin slices, then lay out all the slices on the examination board to examine the specimen. This is a real case. After we ink all the 6 surfaces, then we slice the specimen into thin slices and put them on the board. As you can see, this specimen is sliced into 6 slices from lateral to medial aspect. And we orient each slice with the letters S represent superior, A represent anterior, P represent posterior, and I represent inferior. Then we have the lesion from slice number 2 to number 5, and also there's a biopsy clip on slice number 5. And we took the sections. A1 is the biopsy clip include the anterior margin. A2 is a tumor with inferior and posterior margin. A3 is tumor in slice number 4 with anterior margin. A4 is tumor. A5 is a representative section in slice number 6. A6 is a representative section of the lateral margin in slice number 1, and A7 is a representative superior margin. So this is how we generally grow a lumpectomy specimen. We have the slice there, we have the map, and show where the lesions are, where the biopsy clip, and how we take the sections. Here's another example of slices after we slice the lumpectomy and put them on board. And after we take section, this section will put in this orange color cassette, and this specific tissue will be processed so that we can examine the tissue under microscope. As I mentioned, some patient with limited ductal carcinoma in situ is performed by lumpectomy. However, the DCS is really hard to identify by gross examination. We have the X-ray machine in our laboratory that can X-ray the specimen. As you can see, those bright area are the calcification areas where the DCS is, because DCS is frequently associated with calcification. This is ductal carcinoma in situ on the microscope. We can see this tumor proliferation, some area with necrosis, that's when the tumor cells die, and also calcification. Those dark pink area are the calcifications. This is the invasive carcinoma. In contrast to the ductal carcinoma in situ we just saw, tumor cells break through the normal structure and invading into adjacent normal breast tissue. After the tumor becomes invasive, the tumor have the chance to access lymphovascular channels and distant metastasis. So this is one example of our pathology report. Part A is right axillary sentinel lymph node. There were 2 lymph nodes taken and both were negative for tumor. And then we have the lumpectomy of the right breast. This is an invasive ductal carcinoma. The grade is 2 and the size is 3 centimeters. We saw focal lymphovascular invasion. All this, the tumor type, Nottingham grade, the size, lymphovascular invasion are all important prognostic factors that correlate with patient's prognosis. And also we will report the margin status, which is very important for patient management. For this specific report, the invasive carcinoma is 0.1 centimeter from anterior margin, and all other margins are widely free carcinoma. At Emory, when we say widely free carcinoma, we mean the tumor is at least 5 millimeter, that's 0.5 centimeter from the carcinoma. I think that's the end of my talk. Thank you very much for your attention. I'm happy to answer any question you will have.